Shear with the Pacific Health Coalition here today. Welcome everybody to Health Tie. Those of you who are new, welcome. Our stakeholders, welcome to you as well. What I'd like to do is introduce Pat Shear with the Pacific Health Coalition, and then really just turn the presentation over to him. We have about 20 minutes for him to tell us about his organization, and then 10 minutes for questions and answers. So thank you everyone for joining us today. If you could please mute your mics if you are not speaking, that would be helpful. And I'm going to turn it over to Pat. So Pat, welcome. Thank you for joining us here today. It is really nice to have you here and to tell us about your organization.
Well, thanks, Jacqueline, for doing this, not only what you're doing now, but what you've been pursuing over these several years that you've invited me to attend. And what I hope to do is tell our story, which is oddly a story of hopefulness and perhaps a different view at tackling some of the problems that those on this call have typically been faced with. And at the end, I hope to identify some untapped opportunities that others may wish to exploit. So, well, let's see, maybe I won't. And there we go. Who is this guy that we're talking to? I've been in health insurance much of my professional career, both in the private sector and the public sector. I innovated something for a large health insurance provider back in the 80s. And when I went to work in the public sector, somebody found out and appointed me to all kinds of advisory committees until the ultimate punishment. I was adopted as the director of retirement and benefits and worked there for 4 years. And we were able to turn that division from a division that was struggling to a Denali Award winner based on the really good information that the folks that had worked there for a long time had. And finally, I was willing to listen because I'd been working with them on the advisory committees all these years. And the punishment for that was to become the chief information officer for the state of Alaska. Sorry to leave the division. It's still one of my favorite jobs. And even since I left there, I've been in healthcare advisory roles of one kind or another. But what we have always seen in those roles, and literally on my signature, I spent billions of dollars paying healthcare providers to provide care for public sector, both active and retiree populations, both in Alaska and out of Alaska. Most of that money was spent in Alaska, but a great deal of it was spent in the Northwest. And in all those hand-wringing about those billions of dollars going out the door and all the implications of that, in other words, no money available for other important things, we were trying to figure out what's not only the symptom, that was the frustrating part, but what's the root cause? And over the years, a couple of root causes have presented. And one of them is something happened in the 1960s. If you can see the graph on your screen, you'll see this precipitous increase. It's interesting, the $147 per capita is about the same as the receipt my mother showed me when I was, and some of you will know what I mean by this, born at the bank in Fairbanks. She was in the hospital for 3 days when I was born, and it was about $160 for my birth and her convalescence before we went home, to the number you see on the far right. But something else happened to precipitate this, perhaps, and it's a theory I have, and it is the government stepped in and said, because employers wanted this and they had good lobbyists, they said, hey, let's create these tax-free employee benefits, and we will now be able to attract workers, keep workers, provide for workers and their families, but we won't have to pay taxes on it. It was the beginning of that separation of the consumer and the provider with a third party in between. And that third party has been an insurance company, it's been a self-insured trust, and it's been the government, over these years, and we can see the effects. And Alaska is even worse. We're a captive market. We've had certain disciplines like orthopedic surgeons and anesthesiologists essentially unionize and ratchet up their charges every year under the 80th percentile. They've also used that, and they'll pick one person and say, okay, it's your job to charge outrageous numbers. That becomes the force in finding a new normal, and we keep ratcheting up and up over time. And that's some of what we've seen in Alaska, which is now standing for some of those at 5 times or more than Seattle rates. And I know about Seattle real estate. You simply can't say it's the freight or it's the real estate costs. Here, there are other market factors at work. And those market factors are generally the result of well-intentioned regulatory or government action. And let's see. Let's go to the next one. Here's an example. In 1999, the law was changed to prohibit the reimportation of insulin into the United States. It was done buried in a law way down, like on page 1000 or 500 or something of that nature. And the language didn't say thou shalt not, but it effectively prohibited the reimportation of insulin, at which time, you can see by the graph, the prices for insulin began to increase precipitously. Problem here. Patients didn't complain right away because they never saw it. They were effectively separated from the increased costs of the insulin until people would lose their insurance for some reason and would walk into the pharmacist to buy some, and it was now over $300. And you can see some of the trend-inducing factors that occurred. Medicare Part D, Affordable Care Act, both of those further separated cost-sensitive individuals from the true cost, and therefore the manufacturers and suppliers felt unrestrained in increasing their market share. What are the counter trends? Well, the contrary trends that you might see are, let's say, cosmetic surgery or LASIK surgery. Neither are covered by insurance unless it's a result of an injury. And yet the costs for both cosmetic and LASIK have steadily declined over time. So one is trending up and the other is trending down. So understanding all those activities in the market, when Fred Brown called me and said, Pat, we need some help. We're doing something really fun over here, I was very intrigued. And it was the Pacific Health Coalition. It's a private, nonprofit organization that does not accept any federal or state funds. And they serve an ever-growing number of individuals in Alaska, and it's now extended outside to Washington State, Colorado, Nevada. We have some plans in Oregon that have joined and some in Northern California that are talking to us, because they recognize something unique. This is not insurance. This is for self-funded plans that have a tight connection with the participants for whom they pay medical expenses. That is the secret sauce. Each plan remains independent and unique. We have 40 some different discount products available, and each plan selects a unique mixture that is just for them. Our organization is staffed by 3 part-time individuals. We pick up attorneys or negotiators as needed. We don't have any office space, and our website is crummy. If you've looked at it, we don't spend a lot of money on that. But we are a pooling organization. But the secret sauce for us, again, is that we allow each plan to maintain its unique connection. We've talked about that. Some other things that we do are coalition health centers. We've opened 2 coalition health centers, and our coalition with reserves actually signed the lease. We paid for the new furniture and the build out. We even bought a used reconditioned x-ray machine for the 2 clinics, the one both in Anchorage and Fairbanks. And now our customers, which are a number of these local plans, are about 40 self-insured plans in the state of Alaska that are members, representing those 110,000 people. You can go in there and get an x-ray of your leg and have it read for $28. $28. Because we have broken the traditional model of we're asking or we don't want to know. We just close our eyes and say, all right, provider, you do what you think is best, and we'll pay whatever the rate is. We have been very involved in the cost per unit of service, calculating that and trying to find the right partner, which is Beacon Health right now. We've also been using case rates with one of our partner hospitals, where if somebody comes in for a particular malady, we know what they're going to spend, and the hospital sticks to that rate. And the last bullet is probably the most important. Let me share an example. In Oregon, we have members who are school districts, and they escaped back when the statewide healthcare authority was first imagined in Oregon. They took advantage of the opt-out program, and every year they call all their teachers and staff into a gymnasium, and they look them in the eye and say, it's up to you to be wise healthcare consumers, because if we save money on the health plan, we'll have more money for wages, for improvements, for the classroom. And here's how we get that done together. And then they structure, based on their advisory committees, ways of helping people be wise consumers of the healthcare that is available to them under their plan. It's what I would consider really the holy grail of trying to do something about the problems we all face in healthcare delivery. We saved our members $500 million last year. Our partners that you see there are in the magnitude of the savings. Aetna has helped us negotiate in some markets where they have more sway. We've helped them negotiate in Alaska. Aetna now actually rents our discounts that we negotiated with Alaska Regional Hospital from us in order to make them available to their insured clients. There are some others that I didn't mention. National Cooperative RX is, like us, a coalition of coalitions. And the members of this coalition hire an executive director and some pharmacists to negotiate with the large pharmaceutical companies. And we demand, as part of our contracting, that they return all rebates to the members of the plans. So we return on average about $2 million a year on top of the $20 million a year in savings, because our negotiators tend to be better than just about anybody else. What about the rest of us? I mentioned to you that Aetna was so impressed with the work that we were doing, and we were hearing from the legislature that very question. You guys are doing great, but we want to do a healthcare authority because we want to do something for everybody else. And besides the fallacy in that thinking, we offered, hey, why don't you let us work on it for a year? And we found a willing partner in Aetna, and they priced and got through the Division of Insurance a plan for South Central Alaska that incorporates a lot of those discounts that saved our other members $500 million. The challenge is, and it's not to be minimized, it's still insurance, and it still separates the consumer from the provider. So let me go into the big idea, and this will be the final slide before we go to questions here. Over time, our users have been separated. When I was at the Division of Retirement and Benefits, we were talking to an East Coast insurance company that had pioneered really a wellness plan, primarily a wellness plan. And we watched them for about 3 years, and in the 5th year, they went bankrupt. Why? Guess what? Human nature. The people that were obese, the people that had underlying health problems, the smokers, those that we know lead to very high spending in the final years of life, stayed away from the plan in droves. Guess who used it? The healthy people. They were there every year getting verification that they were doing a good thing. And so the costs went up for preventive care, but there were no savings on the downside. and that outfit went broke. And it's always very, very difficult to get the human animal to respond to what you and I might believe are appropriate motivators to improve their health. But there is something that really, really works, and it's the informed self-interest of the hopelessly modified market that we experience. We'll never go back to a complete free market model, but there are elements that we could introduce that would take us back down the spectrum to the other side, away from increasing regulation and control. Apple and Amazon. Folks on this call probably have used those services and have been relatively happy with them. And yet all the forces that they brought to bear to make their products really great and to make them market leaders are not available to us in the healthcare industry. So the Pacific Health Coalition really has tried to preserve and improve those areas where the consumer of the healthcare really does have a lot to say about what they spend, where they go. I should say that when we negotiate a discount, it involves steerage. In other words, the laborers, for example, or the electricians trust may say, we're going to get 50% off. And those are the kind of magnitudes we're talking about. 50% off if all of our members go to this provider and not those others. And they're willing to take the heat from people who might argue that they would rather go and see this other doctor because after all, the deductible and the copay are the same. But now we're changing that up, and you've all experienced that reduced reimbursement rates. It's an open field, and this approach has been widely neglected. There is an orthopedic surgeon firm in Oklahoma, for example, that has decided not to take any third-party payments. What do you think their rates are? Their rates are 20% of what everybody else in the marketplace is charging, and they are thriving. They are busy, they are full. There are individuals who are flying into their location to have them do the work. They're a center of excellence because they get so much volume that moves through. But whatever we do in this field is going to be disruptive. I've been sitting in rooms talking about transformation, about the healthcare authority over the last several years. And in every case, we don't talk enough about what this will do to the economy, because anytime you take $1 billion out of an economy, even if you feel good about saving money on healthcare spend, you're going to blow up a whole nother section of the economy. And bankers are interested because they have doctors who owe them money on a 5-year note on a brand new building. You have employment, people who are interested in that. You have unionized employees who are very interested in continued spending. And if we fail to address those, and we try to do it only in a regulatory fashion in Juneau or in Washington, D.C., there will always be those that are willing to spend a lot more money than you and I who will be effective. But if we go grassroots and show people that they can once again be the commanders of their healthcare spend, and there are some ideas about that. How about SNAP cards, for example? We count on people who are getting support for their nutrition are using a card that has value, and they shop with that and they get their best value. And we can all share examples where that doesn't work, but I think there are a lot more ideas and pilot programs using honest data that may help us chart a path out of this, always nibbling at the edges, looking at the symptoms and never really going for the root cause.
Awesome.
I'm done.
Pat, first of all, excellent. That was a wonderful presentation, and your timing is spot on. You've left us plenty of time for questions. I'm going to jump in and ask, this sounds amazing. Why wouldn't people join you? What kind of comments have you had about what would be the reasons that people wouldn't join?
Oddly, there are two. First barrier to joining us is you must be a self-insured or a self-funded plan. and not everybody can do that. We have some remarkably small school districts that are members of our coalition, but that said, you have to be a self-funded plan. The second is, even though we have 40 some different discount products available to folks in Alaska, not all the trustees are willing to face the withering complaints that will come from members who are now asked to change their consumption patterns. Some trustees are more successful than others, and we do coach trustees on how to bring that message across. We attend a lot of annual meetings and planning meetings for these funds, and we offer ourselves to take the abuse, but those are the two most common reasons.
All right. Thank you very much. I have other questions, but I'd like to open it up and see if there's others that would like to ask questions.
Was that? Yeah.
Just wow. Just wow. That was just such a clear 15-minute presentation on one of the biggest things that we're facing. And Pat, I'm the executive director for the Alaska Association on Developmental Disabilities. And a number of our nonprofit organizations went into self-insured plans that are now very, very, very concerned about what's going to happen to their rates with, you know, a potential COVID case or, you know, things that are happening. So would a nonprofit organization self-insured plan, and I'm not sure if it's like one organization or a group, but they're all nonprofits, would they be eligible?
Absolutely.
Could I have you talk at a meeting?
I can't think of any reason why not, let me say, but I'd be happy to follow up after this and start a conversation.
Oh, that would be fantastic. We have a chief finance officer group that's very active that meets once a month, and so I will connect with you after this. And just
very well. I'm
thank
glad you mentioned that.
Thank you for your work. Thank you for your insight. I'm really impressed.
All right, I just want to take a moment and just say, this is why Health Tie exists. This is exactly why. So you have made my day, Lizette. So awesome. Who else has a question while we have Pat with us?
Well, I guess I'll go. My name is Bevan.
Wait, Carolyn Brown raised her hand.
Oh, sorry.
Didn't you, Carolyn? Well, you're on mute.
May we hear from Bevan and then we can hear from Carolyn? Brown, Bevan, would you like to unmute and maybe ask your question?
Sure. So you mentioned Seattle prices. That's where I live. And Alliance for a Healthy Washington, which is our organization here, we work in the policy realm. So I guess my question is, you know, given that your alliance and coalition is fairly small in the grand scheme of things, how do you manage to negotiate these prices? I mean, what is the leverage that you utilize in order to do that?
I mentioned, you know, this covenant relationship between the plan participants and their trustees and how effective that is. Similarly, we have found a number of organizations that are trustworthy partners who are willing to take risks. None of this was done without taking risks and understanding that those risks were very real. Renologic is one of those partners that has realized for us, I know it sounds ridiculous, but 80% discount in dialysis. And they're in court right now because the providers don't like the rates that they bring into the door and say, our customers are coming here, you have to at least sit down and talk with us, and here's our rates. And in a weak moment, they sign off on it. And then when we start bringing this volume, they realize, hey, wait a minute, we're not so happy about it. So we form strategic partnerships with folks that are willing to take a risk. And we see.
Pat, you suddenly went mute.
How about that? Maybe I got
We
excited.
lost the last 3 sentences.
So we are members of the Washington Healthcare Alliance, by the way. Fred Brown attends those regularly. I've been down to meet the folks, very interested in the work they're doing. But essentially, the message is we're joining forces with people who are innovative, who believe that they can change these things at the root cause, and who are willing to join us in taking risks.
Bevan, did you want to follow up with any other questions or?
I mean, Pat, if you'd be willing to exchange information, I have probably a whole host of things I'd like to go back and forth with you on. You know, one of the things that
Grateful. That'd be great.
that are challenges for us, of course, are reimbursement rates, you know, especially looking through the policy lens, you know, looking at larger state plans or county plans, et cetera. So as we start to shift, you know, we have to change the full cost of care in this country and starting to look at how we do that. Because as you're saying, like, it's not just a rate setting, right? There's all these other pieces of what makes our healthcare so expensive in this country. So if you're willing to, you know, go back and forth with me offline, I'd be
Absolutely. Jacqueline can provide, if it's not in the cloud here somewhere already, my contact information, and I'd be happy to. We're always welcome the discussion. We grow from it.
Yeah.
Right. Awesome. So Bevan and Pat, another good reason, just like Lizette, for connection. Carol, I would love to have you now ask your question. Could you please tell us your comments?
Okay, I should be unmuted now. I'm very interested in how you choose your providers and what happens when people have to go out of area.
You know, it's actually that's a great question. We have one of the scrappiest negotiators I've ever met that works for us out of consulting firm here in Anchorage, but he has a national reach through his firm, and he has made it his business to be very aware of what's going on in the local markets. One of the ways we won a discount of between 50 and 60% with one of the local orthopedic practices was he was aware that there was unrest in the firm and that they were going to split. And so he was able to approach both. And this answers the second part of your question. We approach them with a reasonable offer. For example, we will pay you 30% above Seattle, but not a penny more. So we're going from 5 times Seattle to 30% more. We take a big bite, and then we work with them, and it took us about a year to finally get ink dry on the paper. And then the promise of our trust funds directing people to their practice so that they could still pay the rent was the circle of life, so to speak, in contracting in that respect. That's how we decide. We reach out broadly, and we deal only with those people that are willing to come to the table.
Thank you.
We probably have time for one last quick question. Is there one last quick question in our community? No. Well, as usual, I am really happy to make connections between anyone who would like to speak to Pat and learn more about the Pacific Health Coalition. A huge thank you to Pat. That was an excellent presentation.
Thank you. Appreciate it. Thanks for the opportunity.
Very welcome. And you and I will, of course, stay engaged and still try to continue our work together. And thank you, everyone, for joining us here. Our next presentation is in 2 weeks at 1 o'clock, and looking forward to seeing you all then. So thank you for joining us today.
Good to see you again.
Any chance we can get the slides, the PowerPoint?
Sure.
Thank you. Okay, wonderful. Thank you, Jacqueline.
Of course. Nice to see you all. All right. Thank you so much. Okay. Goodbye, everybody. See you in 2 weeks.